Thank you very much, Professor Kokeling, for this very nice conference. I enjoyed it really a lot. You have a very powerful tool with your writing, and the publications coming out from your results are always have a high level of evidence. And I think it's one of the sources of truth, if we can speak about truth in medicine, that we all follow with great attention. So now I have the pleasure to give you again the opportunity to introduce yourself, the German session that Jean-François Gillon has scheduled to have this year. Each year we have colleagues from one country with a monographic session. It has been previously a Spanish one, an Italian one, and now this year we have a German session. You are really a very, very active group. I think a leading group today in abdominal wall surgery, and I'm pleased to meet all German colleagues here today.
Yeah, many thanks again. It's for us a huge honor that you gave us the possibility to organize the German session, and we have to thank you very much. We enjoyed it, and I'm sure my colleagues will present you very nice data, and we will have the opportunity at the end of the session to discuss all these presented data. And again, many thanks for the opportunity.
Thank you. So we have to welcome 4 German colleagues and 4 French colleagues too. So for the moderators, we will have Johan Renard from Reims, Jean-Luc Bouillot from Paris, Philippe Ngo from Paris too, and myself from Dijon. And the first presentation we are attending is the one by Henning Niebuhr from Hamburg, who is explaining us why he thinks that the results from incisional hernia, primary ventral hernia, and diastasis should not be pulled. You have already underlined that in your presentation, Professor Kokerling, but I think he's going to insist on this point. It's a very interesting point because we have simultaneously a publication from the Club Hernies really about the question of the width versus the fact that the hernia can be primary or incisional. So this is really a hot topic. Thank you very much, Henning Niebuhr, for your presentation. Go ahead.
Comment classer les hernies ventrales primaires, incisionnelles et la diastasis, et pourquoi les résultats ne devraient pas être poulés? How to classify ventral and incisional hernias and rectus diastasis, and why the results should not be mixed. The answer seems to be clear. Do not compare apples to pears. We have to deal with 3 to 4 different entities: umbilical hernia, primary abdominal wall hernia, incisional hernia, and rectus diastasis. To put order in this muddled situation is the purpose of creating classifications. The EHS classification of primary abdominal wall hernia seems to be very simple. The hernias are divided in midline and lateral, the midlines in epigastric and umbilical, and the lateral in spigelian and lumbar hernias. Classifications usually result in often controversial discussed guidelines and recommendations. A guideline group presented the results in 2019 at the EHS Congress in Hamburg, as you can see on the slide here. A TED voting revealed controversial opinions according, for example, the recommended use of mesh in every form of umbilical hernia. We know that there is a huge number of colleagues not always following the guidelines. Reason for that behavior is a long time experience in practical work, which may not be underestimated. But there's another problem. In 7.8 of primary umbilicals, laparoscopic preliminary operations had been performed like lap chole and lap hernia. In 4.0% of primary epigastric, the same was seen. By definitions, these are secondary trocar hernias. In 4.04% of primary umbilicals and 6.05% of primary epigastrics, they were designated as recurrent hernia. Again, by definition, these are secondary incisional hernias. Not so simple. This is the well-known and regularly used EHS classification for incisional hernias. That one is a bit more complicated. The incisional hernias are divided in midline and lateral hernias, which are subdivided in M1 to M5 and the lateral in L1 to L3 and lumbar. The length and width of the hernias must be measured. This can easily be done vertically from the top to the bottom edge of the hernia and transversely in the widest position. In case of Swiss cheese hernia, the issue to be addressed is a little harder. It must be done from the uppermost edge of the top hernia to the lowermost edge of the bottom hernia. We have to deal with a very wide range of incisional hernias, from a little trocar hernia to the largest LOD, loss of domain situation. For medium to large incisional hernias, but also for primary epigastric hernia, there are several recommendations for treatment. The almost revolutionary Milos concept by Wolfgang Reinpold is to be mentioned as mainstream in the treatment of abdominal wall hernias. Large incisional hernias, more than 10 centimeter and loss of domain, must often, amongst others, be treated with several forms of compartment separation, for example, transverse abdominal release or ETA. As an alternative to these sometimes possibly complicated procedures, maneuvers, the application of the new fasciotense treatment can be considered. The basic idea behind this technique is to stretch relaxed muscle groups in order to achieve an almost tension-free closure of the abdominal wall. It was already inaugurated, this idea, in 2011 by Eucker, but was refined by Gerion Lil and co-workers in the last time. A highly significant gain in facial length, on an average of 9.8 centimeter, could be achieved. Here is shown how the device is fixed on the patient, put on the patient, and the diagonally holding sutures, the crosswise holding sutures are fixed in the frame, and the last measurement is done. Now the power is controlled, and the tension and the traction is lasting for half an hour. This is very hard for operating surgeons to wait such a long time. It is somewhat complicated to perform the final running suture for closing the front layer of the rectus sheets while still keeping tension on the diagonally crossed holding sutures, but as you can see, it works. No postoperative abdominal compartment syndrome occurred. The last chapter is about rectus diastasis. Rectus diastasis has recently become the focus of attention. Diagnostic tools are clinical examination as caliper and finger width, and the ultrasound with extended field of view. Width measurement 2 centimeter above of the umbilicus and in the umbilicus, but also in M1 to M5 according to EHS classification, are recommended. A comprehensive classification of rectus diastasis was recently presented by a working group around Ferdinand Köckerling at the EHS Congress 2019 in Hamburg and later published. The classification contains the width of the rectus diastasis according to Rennie and the type of concomitant hernias in patients with rectus diastasis, the number of pregnancies and multiple births, and the skin condition. No skin laxity and no skin folds, S0, minor skin laxity and only few skin folds, S1, and major skin laxity and extreme skin folds, S2. And the diagnostics of rectus diastasis are also completed in this slide and in the rectus diastasis classification. The classification results in treatment recommendations. Grade 1 rectus diastasis should not lead to operative procedures, but to recovery, exercise, and neurostimulation. Grade 2 rectus diastasis with minor skin laxity and only few skin folds is an indication to comparably less invasive operative procedures as Melos, E-Melos, or ELA. Grade 3 rectus diastasis with major skin laxity and extreme skin folds can only be adequately treated by a combined plastic and abdominal wall surgery procedure, MAO maxi open. Impressions of this combined procedure can be seen in these photos. Bottom to the right side, you can see the final result after a long-lasting 2 to 3 hours lasting operation. And our conclusions are: comprehensive evidence-based classification are necessary in order to find a way to a tailored therapy of the different forms of abdominal wall hernias. Classifications and recommendations are important to gain appropriate and evidence-based results. Thanks for your attention. Merci pour votre attention.
Thank you very much, Dr. Niebuhr, for this very nice presentation. We will discuss all presentations at the end of the session, and this will allow that you all can ask your questions on the live chat. So on the site online, you can write your questions or comments, of course. Just please be precise. Tell us to which presentation you are making your comment or your question, and it's even better if you give us also your name, and so we can put sometimes a face in front of the comment. So thank you very much for your questions and comments, and I'll let the next presentation. I don't know who's introducing it.
Jetzt erst, ich möchte die deutschen Chirurgen grüßen. Ich konnte Deutsch sprechen, aber jetzt, ich habe alles vergessen. Und jetzt, ich will auf Französisch sprechen. Donc, je suis très heureux de participer à cette session allemande, car depuis toujours, la chirurgie allemande a été experte et très rigoureuse dans la chirurgie de la paroi. Et je me souviens de mon patron Jean-Henri Alexandre lorsqu'il avait noué des relations très fortes avec l'équipe de Troyes à l'époque. Donc je suis très heureux d'entendre maintenant Ralph Lorenz qui va nous parler un peu des classifications et des recommandations pour la chirurgie de la paroi abdominale antérieure. Et donc, je suis très heureux d'apprendre toujours des nouvelles choses. Et donc, je lui cède bien volontiers la parole.
Dear colleagues, dear ladies and gentlemen, thank you very much for this kind invitation. I want to talk about standardization versus individualization of EHS guidelines and the tailored approach for ventral hernias. I have nothing to disclose. I have no conflicts of interest regarding this presentation, and I will come up with 3 topics: the evidence and guidelines, the reality and controversies in the repair of ventral hernias, and the tailoring concept. What could it be? The group of surgeons, as you can see in this picture, is from almost all European countries, as well from America. And it was a great honor for me to be part of this consensus group. We met up in Amsterdam, Malmö, and Hamburg. And finally, we have published 2 publications. They are the open access. Everybody can read them. The guidelines for umbilical and epigastric hernias, published in the British Journal of Surgery. And the second one is in BGS Open, the treatment for primary ventral hernias in rare locations in special circumstances. Both publications are published this year, and we have included a treatment algorithm. This treatment algorithm says normally, of course, you should choose always a mesh. In cases of lower than 1 centimeter gap, you could choose a suture repair as an option. What is the reality and the controversies? And of course, I just remember a publication or an editorial from Giampiero Campanelli, and he stated, of course, the ventral hernias are poorly clarified in case of treatment. There are open questions. What should you do in case of rectus diastasis? Is there a place for IPOM? Is there a place for any devices in ventral hernias? We have 2 more publications about the reality. One is from US, and the mesh procedures take the biggest part, yes, but 31% are suturing, almost in small hernias, might be, but also there seems to be a huge place for patches and as well for the IPOM and endoscopic repairs. In Germany, we have this year a publication in September about the hernia database and the reality of small ventral hernias. It seems to be totally different. We have 79% suture repairs and almost 94% open repairs. For an umbilical or epigastric hernia with a defect of lower than 1%, we have asked during the European Hernia Society meeting in Hamburg last year, and with the Survey Monkey during all the members of EHS and AHS. And finally, of course, most of the surgeons are suturing these small defects. In 79%, they don't use a mesh in small defects. If you're doing an open mesh repair, you use any kind of patches. They are normally, of course, for intra-abdominal use. And once again, a surprise, yes, 58% of the participants of the European Hernia Society meeting in Hamburg say yes, they use patches, and with the Survey Monkey we could find 36%, not even the flat mesh. But if you ask the question in a different way, do you normally use a flat periperineal mesh? Yes, most of them are using them. I think it looks like there is a difference between the second question and the first question. Most of the surgeons are preferring a tailored concept, and they agree with recommendation regarding this. What about the tailored concept? And the tailored concept is something which keeps a balance between standardization and individualized concepts. Umbilical hernias are very common, and the majority of umbilical hernias are in 3 different age groups. And of course, there is the question, should we treat them always in the same way? With childhood, after pregnancy or older age, most of the majority of defects seems to be small. And there are a lot of influencing factors. Classification is one point, age, comorbidities. The simultaneous rectus diastasis plays an important role, and the individual exertion or pregnancy. Finally, don't forget the wish of the patients. The operation techniques, of course, suturing is one option. Open mesh could be anteriorly, posterior with a knife bomb, or endoscopic with all the new techniques which are, I think, in favor of some of our surgeons. The material plays a second important role. We have, of course, the flat meshes, and secondly, we have a lot of pre-shaped meshes or patches. The mesh overlapping, what could it be? 3 centimeter, 4 centimeter, 5 centimeter? The fixation should be resolvable or permanent, and do we close the gap or not? So we have finally the option tailored concept is something which is related to the surgeons, and the surgeon has a huge impact. Of course, the own experience, key opinion leaders, their own school and economy, and of course the individual facilities plays an important role. You should keep a balance between, of course, simplicity, safety, education, cosmetics, comfort, and risk, complications, intra and postoperative recurrences and pain. The summary, I came to the conclusion, I think we have a lot of multiple variables. The scientific evidence seems to be very low. In most cases, a mesh repair is recommended. Up to 1 centimeter suture seems to be an option. Standardization is needed, but almost for all these special techniques. And individual therapy is allowed, but you should always reflect your own quality. Thank you very much and have fun with the MESH conference. Best regards from Berlin.
Thank you very much, Ralph Lawrence, for this nice presentation about really controversial points that we could discuss at the end. The next presentation is being introduced by Philippe Ngo, a surgeon working in Paris and very active in the hernia club.
Yes, thank you, and thank you to the Wolfgang Reipold. I am very pleased to hear him about ventral hernia and diastasis recti. We know that the results of ventral hernia repair are not the same if patients present diastasis recti or not. So, do you perform the same procedure if the patient present or not diastasis recti? And for Milos and Hilar technique, especially when patients present diastasis recti, it's not always easy in order to obtain a tension-free suture. Do you have any trick? Do you close the posterior sheath? And how do you close the anterior sheath, especially with diastasis recti? And thank you to hear you, Wolfgang Reipold.
Merci, cher Jean-François, chers collègues, chers amis. Merci beaucoup pour votre invitation à MESH 2020 virtuel. C'est dommage qu'il n'y a pas une rencontre avec vous à Paris. Malheureusement, mon français ne suffit pas pour présenter. L'intitulé de ma conférence est Hernie ventrale et diastase de droite, place des nouvelles techniques Milos, Emilos, Hilar. The problems of the old ways are evident. Large wounds cause more infections, and the problems of mesh inside the abdominal cavity are clear. The Emilos concept is a minimal invasive VTAP hybrid concept, transhernial approach, allows preperitoneal retromuscular placement of large standard meshes and the defect closure with anatomically reconstruction of the abdominal wall. Some definitions of Milos: the mini open dissection can be performed with light-armed laparoscopic instruments under direct vision using the endotorch. This is the preferred technique we use. Or it can also be used endoscopically assisted with a laparoscopic video endoscopic equipment. After creation of a space of at least 10 centimeters, you can convert to endoscopic Milos-E-Milos operation, as you can see down here on this slide. Operation starts with a small incision above the center of the hernia defect, then the circumferential dissection of the hernia sac in this fashion, and the circumferential dissection of the hernia ring, followed by the bilateral medial incision of the posterior rectus sheath. Then the operation starts, the mini-open dissection with laparoscopic light-armed instruments starts with the endotorch. Here you can see the posterior rectus sheath of the left upper quadrant liberated from both sides. The next step is the vertical medial incision of the posterior rectus sheath in all 4 quadrants. Here you can see the E-Milos approach with a Lexus port. Incisions up to 4 centimeter can be blocked with a blunt tip port, which you use in TEP inguinal hernia repair. This is a picture of a E-Milos dissection, incision of the posterior rectus sheath versus the xiphoid. The complete closure of the peritoneum, the implantation of large standard meshes with overlap of at least 5 centimeters, and the hernia defect closure with anatomical reconstruction of the abdominal wall. The Milos-E-Milos concept is also very good for the TAR procedure, and lateral and flank hernias can be fixed using this technique. But in my lecture, I will focus on the E-Milos options for the repair of rectus diastasis with concomitant ventral hernia. The first option is the posterior inverting plication of the linea alba. We use this technique in obese patients with a symptomatic rectus diastasis. The next option is the anterior inverting plication of the linea alba. We use this in normal weight or slim patients, mainly young women with postpartum rectus diastasis. And the third option is the sublay mesh augmentation of the linea alba without plication. We use this in obese patients with totally asymptomatic rectus diastasis. In 2018, we have published a classification of the rectus diastasis with the German Hernia Society and the International Endohernia Society. The parameters are the length, the width, the type of bulge, the number of pregnancies, and the skin condition. This is an endoscopic view of a large, broad rectus diastasis with many microhernias. These microhernias are nicely visible using endoscopic techniques. If you overlook them, the recurrence is sure. This is the port alliance of E-Milos repair of rectus diastasis with umbilical hernia. In slim patients, 3 mm working ports can be used. I will show you a short video of the technique, E-Milos operation of a postpartum rectus diastasis and umbilical hernia. The instruments, 3 mm working ports, endotorch. Operation starts with a little incision, the upper level of the umbilicus. Transhernial approach starts with a mini open dissection. Here you see the longitudinal incision of the posterior rectus sheath in the left upper quadrant. After creation of sufficient space, a conversion to E-Milos dissection. Here you can see the incision of the posterior rectus sheath dissecting upwards, and this is the dissection downwards versus the symphysis. In young women, the mesh shouldn't be too big. Maximum size in our institution is 25 by 15. Mesh lies nicely and flat. And then the next step is the mini-open subcutaneous dissection. The fatty tissue is removed from the linea alba, first mini-open, and then after creating a sufficient space, again endoscopically. And finally, the anterior inverting plication of the linea alba using barbed sutures, long-term absorbable 0. The last 3 to 4 centimeters of the plication can be performed mini-open transhernially. The umbilicus is reconstructed, and after 3 months, the cosmetic result is very good. In obese patients, the plication can be performed in the posterior fashion, as you can see here. The posterior plication sometimes leads to an ugly rim in the midline, palpable rim, and in slim patients, this can be very bothersome, and the cosmetic aspect sometimes is not very good. So it's not recommended in slim young women. Should always take 3 bites with 1 stitch. This is the final result of the posterior inverting suture of the rectus diastasis. Some examples of postpartum rectus diastasis before and after E-milus repair. Another example, a young woman, excellent cosmetic result. In women with a lot of skin laxity and very broad diastasis, E-milus and milus are no good techniques. In this cases, you have to do an abdominoplasty, and we do it in combination with a plastic surgeon. We also do the implantation of the mesh in the subplane, and the cosmetic result, again, very good. The endoscopically assisted linear alba reconstruction, ELA, was published by Ferdinand Köckerling. It's a mini open dissection with gasless endoscopy. The recti are not completely brought to the midline. Flaps of the anterior rectus sheath reinforce the linea alba, and mesh replaces the anterior rectus sheath and additionally reinforces the linea alba. As you can see here, this is the beginning of the operation. The type of incision is shown. Blunt dissection with endoscopic equipment, gasless endoscopy. The fatty tissue is removed from the linea alba and the anterior rectus sheath. The anterior rectus sheath is incised on both sides. The flaps are brought to the midline, and the midline is reconstructed, as you can see here. And then a mesh is inserted, replacing the anterior rectus sheath and reinforcing the linea alba. This is the final result. Good cosmetic aspect. Ferdinand Köckerling and co-worker has published the first 140 operations with very good results, 1-year follow-up. We have published the first 600 incisional milus and E-milus operations in Annals of Surgery, comparing our results in propensity score matching with open sublay and lap IPOM operations. The 1-year results I've presented at MESH last year. And now I present the 5-year results, and they confirm absolutely the very good results after 1 year. E-milus, milus versus lap IPOM, significantly less chronic pain and recurrences. And the same holds true milus, E-milus versus open sublay, 5-year results, less recurrences and chronic pain. So I conclude, very promising first publications of milus, E-milus and ELA operations in our hands after 10 years experience and more than 3,500 milus, E-milus operations with low complication, recurrence and chronic pain rates, allows minimal invasive sublay repair of nearly all primary incisional ventral hernias of midline and lateral compartment. E-milus is suitable for TAR, E-milus, milus and ELA are suitable for rectus diastasis repair, allows the easy resection of the hernia sac, defect closure and skin mobilization and umbilical reconstruction, and it's cost effective and saves approximately 1,200 euro in material costs versus lap IPOM. And of course the good results of Ferdinand's working group and our working group have to be reproduced in future trials. Merci beaucoup pour votre attention. Je vous invite à Hernientage 2021 à cause de Corona virtuel, mars 5e et 6e. Merci beaucoup.
Vielen Dank, Wolfgang, für diese schöne Präsentation, für diese Technik. Die ist ganz elegant, schick sagen wir auf Französisch, wirklich
Merci
schick.
beaucoup. Merci beaucoup.
So it's my pleasure to give the next presentation will be introduced by Johan Renard. It's a topic he loves. Loss of domain is something he really loves. So go ahead with it.
Juste avant, excuse-moi Pablo, peut-être peut-on rappeler à l'audience qu'on peut poser des questions et que je me ferai un plaisir de relayer toutes les questions écrites à l'oral.
Dankeschön, Pablo. Hello. Dankeschön for to be here today. I was very good in German, but today all is lost for me. So it's my pleasure to introduce Mr. Guido Baschlemen from Leipzig to speak about loss of domain and component separation using the robot. So thank you, and I give you the speech.
Dear colleagues, thank you for the invitation to speak about robotic surgery and special hernia cases in this very, very interesting form of conference. To the beginning, some facts about me. I like hernia surgery, and in particular, I like new inspiring methods. So I'm using laparoscopic IPOM since 2003, the different methods of component separation techniques since 2010, and I started robotic surgery at the end of 2018. Robotic surgery has become an increasing influence in the general surgery during the last years, but it seems we have still more questions than answers. It's like the black hole in the space. We know it exists, it is fascinating, but we don't really know what the benefit of it is. As with any other new methods, we must ask, what do we expect from robotic surgery? We are in expectation of even less of pain, of tissue damage and complications, furthermore a faster recovery and a better post-operatively outcome, and we hope of a lower recurrence rate, especially in hernia surgery. What do we actually know about robotic surgery? At first, the need of a long learning curve and a high volume case series. Actually, we have only similar comparing results in the colorectal surgery shown by the roller study last year. We have high costs in purchase, we have high costs for the special instruments, and we have high costs for the maintenance. Especially in Germany, we have an economic problem because there's no adequate reimbursement in the DRG system. When do we need the robotic surgery? We need it in addition to the technical limitations of laparoscopy with advantage of high definition, three-dimensional visualization close to the object, multiple degrees of freedom of the robotic wrists, and a superior ergonomics. So robotic makes working in small spaces with difficult and expensive preparation really, really easier. Concerning hernia surgery, we have good data in any single center case series, for example by Balaser, Carbonell, and Philip Musems. Of course, the industry wants to increase the use of the robotic approach in hernia surgery, and for example, here this supported comparative analysis of robotic versus open transversus release. There are only short-term data published, and the author's conclusion are robotic-assisted surgery was associated with decreased intraoperative blood loss and systemic complications, but there were no data about recurrence rate or long-time complications. To find out actual opinion in Germany, I did a survey by all certificated hernia centers in Germany, Austria, and Switzerland, as well as by some hernia experts in these countries. Unfortunately, the feedback was very low. Only 44 of 113 colleagues were answering. Nevertheless, I want to present the results. Only 13 of 44 colleagues using the robot. Only 5 of this 31 other planned in purchase in the next time. All 13 users performing colorectal surgery, but only 5 of these 13 using the robot for incisional hernia repair, and the 8 others don't see an advantage for the robot in hernia surgery. I know it is the current status. In the near future, we will get new devices, new robotic systems, perhaps this new possibilities changing the actual meaning. Currently appears that this special method is only performed by individual surgeons. Under the aspect of loss of domain hernias as a part of complex hernias, we have differentiate to decide case by case about the use of robotic. So that's our own data by incisional hernia surgery in the last years. We have done 4 robotic TAR operations in 2018 and 8 in 2019. Now we have a big problem with our clinic management about the reimbursement, so we had to reduce using the robot in hernia surgery. At the end, I want to demonstrate one case from September this year. It is a loss of domain iliacal hernia on the right side after a partial resection of the iliacal crest for mandibular reconstruction. The patient's risk factors were a BMI higher 35%, a diabetes, or an COLD. So here are the CT scans of the female patient. We started the laparoscopic reposition with using the 8 mm ports of the robot. Then we carry out the TAR and covered the defect with a 30 x 30 cm mesh. The fascia was closed with a running non-resorbable suture. The problem we had was a large hernia sac with massive skin excess, so additionally we need an abdominoplasty. What is my opinion in the moment, knowing the present data and our own experiences? Robotic is a good option for unilateral TAR and for hernias in special localizations like subcostal, lumbar, iliacal, or parastomal. It's also in my mind a good option in cases of loss of domain if a trouble-free reposition is possible. And the robotic is an addition to the open or endoscopic supply techniques. Robotic in my mind is no option for loss of domain hernias with a risk of resection of gut, no option in cases with insufficient closure of the midline, no option in patients with skin defects, atrophic skin areas, and no option for patients with enterocutaneous fistulas. With all the possible enthusiasm in robotic surgery, please don't forget, sometimes we need an open approach. So I finished my topic. I wish you all the best and I hope we see us in real life next year. Best regards from Leipzig. Bye.
Thank you very much for this nice presentation too. And now 4 presentations are open for discussion and comments. I think we could start with some comments from the chat. Jean-Pierre Cossa?
Oh, yes. Maybe we can start with a question of David Moskowitz for Wolfgang Reinpold. Which device do you use to prevent air leak during Emilus procedure? Can you elaborate on it, please?
Yeah, we have 2 options. As I showed in the video, incisions up to 4 centimeters, they can be nicely blocked with a blunt tip port you use in TEP inguinal hernia repair. And if the incision is larger, we use the Alexis flexible port. There are several versions. One has a diameter of about 8, I think, and the next one is about 12. And these Alexis flexible ports with a cap, they are very nice and very fast. It's very fast to close the incision gas tight.
Okay, thank you. We have a question from Johan Renard, from Florent Jurzac, and from Olivier Berlin. May they ask themselves their question, please?
Yes.
Johan.
Yeah, yes, of course. Thank you. My question was, using for Wolfgang, using this procedure for the treatment of diastasis, is there a risk of forming a bulging on the skin? Because
of course there is a risk of bulging of the skin. That is why in slim patients you have to do the sublay dissection in the retromuscular preperitoneal plane, and in addition you have to go online, mobilizing subcutaneous tissue and skin sufficiently in the area of the linea alba and the medial portion of the anterior rectus sheath. Only then it is nicely possible to do an anterior inverting plication of the linea alba. If you go from posterior, you can do it in obese patients and patients who have not so high cosmetic expectations. You can do it from behind, but in slim patients we do it from anterior. So it's laborsome because you have to do the dissection in the sublay plane and in the onlay plane. However, we are 100% sure that the sublay mesh position is better. Of course, we have also thought about onlay meshes like Repa and Scola technique, but I don't like to have the idea of an onlay mesh beneath the little wound at the umbilicus. And if there is a wound healing problem with this only in very rare cases, then you might get a mesh infection.
Ok. Florent Jurzac avait une question.
Il n'est pas connecté, je crois qu'il faut la...
Il n'est pas sur le Zoom, il faut que tu poses la question pour lui.
So the question from Laurence Jurzac is if you don't close the posterior rectum abdominis aponeurosis when you perform Milos, Wolfgang.
Yeah, in most of the cases we don't close the posterior rectus sheath, but of course it's essential to close the peritoneum in between the cut edges of the posterior rectus sheath. And this is in accordance with even with the Reeves and Flamand. I have a publication where it is clearly shown that the posterior rectus sheath should not be closed if there is too much tension. And we had two bowel obstructions when we closed the posterior rectus sheath under tension, and there was a rupture of the suture line and a hole, and in this hole went the bowel, and we got a bowel obstruction. So let's say in 90% of the cases we don't close the posterior rectus sheath. However, in patients with rectus diastasis, in many cases it is possible, especially young women, postpartum rectus diastasis. In many cases, it is possible to close the posterior rectus sheath with almost without any tension, and then we do it.
Okay.
Okay.
More question
from. Okay, come on, Pablo. From Olivier.
Yes, go on.
Okay, question from Olivier Oberlin to Wolfgang Reinpohl. With the size of the incision in your Milos technique, are you not afraid of finding a rate of infection comparable to open technique?
No longer. We are no longer afraid of this. We have, when we started the e-Milos concept 10 years ago, we registered all our operations in HerniaMed, and our infection rate in the publication, for example, we published in Annals, our infection rate is lower than in lap-IPAM operations, because the incision is low, and it doesn't add the risk of infections. So don't be afraid to use a little hybrid incision. It can be compared, let's say, to the laparoscopic assisted sigmoid resection. Even there, the incision for getting out the bowel is very small, and the infection rates are very low there as well. So don't be afraid of these little tiny incisions. And
Thank you.
another absolutely advantage is you can handle the hernia sac easily. You can close the defect faster than laparoscopically, and you can do skin mobilization, resection of scar, reconstruction of the umbilicus. All these advantages you have when you use this little hybrid incision.
Okay, from the
I
audience.
have one. There are no more questions for the audience, Jean-Pierre, I think.
Just a comment about someone who says that there is a general movement running away from intraperitoneal mesh, and the aim now is to put a retromuscular mesh with mini-invasive approach. Mais il y a aussi un commentaire français, et c'est pour ça que je vais le donner en français, qui dit que quand même, la laparotomie, c'est pas si mal, qu'en s'organisant, on peut faire sortir le patient rapidement, et que la durée d'hospitalisation ne doit pas forcément être un indicateur relié au côté mini-invasif.
J'aurais volontiers ajouté que j'ai beaucoup apprécié le topo de Köckerling, même si normalement il n'y a pas de commentaire à en faire, parce que pour une fois, il a vraiment montré de façon scientifique qu'il ne faut pas mélanger tous les hernies ombilicales, les hernies récidivées, les hernies incisionnelles. Et je pense que c'est un vrai progrès qu'une équipe comme celle de Köckerling affirme ça haut et fort.
Oui, maintenant, il faut que ça se traduise quand même dans les recherches prospectives ou rétrospectives, hein, parce qu'aujourd'hui, pour avoir des datas solides en isolant hernie, éventration ou diastasis, ben, c'est quasiment impossible. Hein.
Et deuxième chose, pour ma part, je pense que les hernies et les éventrations, c'est relativement simple et que le diastasis reste un vrai problème de nos jours. Et donc, je félicite Jean-François de nous avoir mis ce sujet à l'ordre du jour parce que ça reste pour moi une des questions en chirurgie pariétale.
So I want to introduce one more question because I really wonder, do you think after all these presentations, the one by Köckerling with the results of HerniaMed and all presentations with new techniques trying to put a retromuscular or sublay mesh with a mini-invasive approach, do you think there is still any place for an intraperitoneal mesh? Any of you wants to give an opinion? Because I do not find, except in extreme cases, you cannot put a mesh in the sublay or retromuscular. Is there any situation you would choose as a first approach to make to put an intraperitoneal mesh?
Yes, it is an excellent question, Pablo. I would say yes, we can use the intraperitoneal mesh when there is no other possibility to push a retromuscular. Okay, I agree with you. Sometimes I used to use an intraperitoneal mesh in case of small lateral defects. Because I think for small lateral defects, for example, a small subcostal incisions, it is perhaps too much to divide all the planes in these locations to put an extraperitoneal mesh. I think for me, it's the only one situation, but for all other situations, I always search to use an extraperitoneal mesh.
From Hamburg, Henning Niebuhr, I have one indication for an intraperitoneal mesh in emergency case. If you have done, for example, in TAR and the transversus fascia is very thin and it's rupturing, then you need an intraperitoneal mesh to reinforce these ruptured fascia and to go on in your procedure. There, I think it is very helpful to have the intraperitoneal coated meshes to use then.
Yeah, from my opinion, there are two other possible indications. The one is a recurrence. So if you had a previous mesh procedure and the patient gets a recurrence, there are very often situations where you can nearly not apply any formal incisional hernia procedure, so you are forced to introduce a mesh into the abdominal cavity. This is one situation. The other one is after transverse incisions with destruction of the rectus sheath and a lot of scar formation, making a good dissection in the planes very difficult. And this is sometimes also a situation where you have to switch over to open IPOM procedure. Concerning laparoscopic IPOM, in a standard case, we have left dramatically this indication using a laparoscopic IPOM and switched over to emilus or milus operation. So in reality, the use of the milus operation has dramatically influenced our indication for laparoscopic IPOM. And I assume that this trend will move on the next years.
Thank you. It's time to close the session. Professor Koeckerling, please, you will close the session.
Yeah, I have to thank all of you, all our friends from French and Germany. It was again a huge pleasure to work with you together. It was a huge event for us that we could organize a German session in France in this outstanding meeting, which is organized every year. And I intensively hope that we will soon have the opportunity to meet again face to face, and hopefully we will have find in the future a new opportunity to see you in Paris or in any other place in France. As I already said, to have a glass of excellent French red wine together, making that an even more outstanding experience. But nevertheless, this was a perfectly organized virtual meeting, and we have to thank Jean-François for his extensive work on it, making it a perfect event. And I hope we will have the opportunity in the future to do the same as often as possible. Thank you very much.
Merci beaucoup.
Merci.